Our next speaker needs little introduction. He's been to Montana several times. Brian Klepper, who's a friend and mentor of mine, has come to us from Jacksonville, Florida. Dr. Klepper, and Dr. PhD, not MD, to distinguish him from some of the other speakers today. Dr. Klepper has been the CEO of the National Business Coalition on Health and has been a nationally recognized author, speaker, and is an influencer of events in healthcare. What I love about Dr. Klepper is the fact that he is a disruptor. We have a healthcare system that everybody recognizes is in transformation, but it seems like it's really hard to get that transformation on the ground. And so he's making that happen around the country. And I'd like to introduce Brian Klepper. Brian?
Thank you. Hi. Before we start, all this started, I developed a relationship with Jim Edwards, and you can imagine how much trouble that's been. But Jim has taught me a thing or two about being progressive in healthcare and doing things that actually work. I have a long and spangled career. For many years, I ran a very successful international healthcare consulting practice. I worked with hospitals and physician groups and health plans and whatnot, and built stuff and fixed stuff. And then I lost my mind, and I decided it would be a really good idea if I personally fixed American healthcare. So I started a national healthcare reform effort, and I had a lot of big players: the American Hospital Association, the Blues, Southwest Airlines, Marriott, Microsoft, people like that. But we realized after working at it for several years that as long as everybody in Congress is on the take to the healthcare industry, you really couldn't get anything meaningful accomplished, which is the same problem we have today. I mean, in 2009, the year that the ACA was written, Congress accepted $1.2 billion in campaign contributions from the healthcare industry in exchange for influence over the shape of the law. That's why the law looks like it does. And as a result of that, all the benefits that accrued went to the healthcare industry and not to us. I've been working on the healthcare costs problem for probably 25 years, and I had become pretty despairing about it. The fix is in, basically. The healthcare industry owns and controls all policy, and they do everything for their own benefit. And that this is a real problem for democracy. When every law and rule is spun to the benefit of a special interest, nothing is ever spun to the advantage of the common interest. And that wrecks democracy. A few years ago, I owned an on-site primary care clinic company. And we used primary care. We built very good primary care medical homes, of course, but we use the primary care practice as a platform to execute a whole variety of risk management strategies all through the continuum. The goal was not just to drive better care and cost throughout the continuum of care, but more importantly, to disrupt inappropriate care and cost in the system, which is the real bugaboo for healthcare. I'll tell you, I don't know whether you can see this far, but I can't see that for much, so I'll just sort of translate for you. The core problem in American healthcare is excess. Excess is the problem. Every single part of the industry, there are different sectors of healthcare. There's the supply chain, the drugs, devices, and supply guys. There's care delivery. There's IT, and there's finance, and there are different groups within each of those. But they have all gamed us so heavily that we pay effectively double what we should be paying and what every other country in the world pays legitimately. Put in that context, it's important to understand how rotten the American healthcare system is. We have mediocre to good, I mean, at best we have good health care, but we have mediocre health care and we pay double for it, which means we have the lowest health care value in the world. And that's, I think, the appropriate way to think about it. And the core problem that this addresses, the problem of excess. This is the meaningful problem in our industry in our lifetimes because it's so strong. I want to tell you that 2 weeks ago, tomorrow, I keynoted the North American Spine Surgeons Conference. They are a confident group. And what I got up and told them was that they deliver double the rate of spine surgeries of anywhere else in the world. And half of those spine surgeries are unnecessary. And a guy came up to me afterwards and he said, I've been coming to this conference for 15 years and you're the first guy that's ever mentioned the elephant in the room. And that is a terrible indictment. You think that's bad? Look at orthopedics generally. Orthopedics does not have an accurate diagnostic methodology, so it ends up working out that very often the way a decision is made is some guy is holding an image up to the light and going, yeah, that looks like it, let's cut. Just the stuff that is done inappropriately and unnecessarily in orthopedics is equal to more than 2% of the entire US economy. Think about that for a minute. Orthopedics in general is by itself is 4.5% of the entire US economy. That's everything. And half of that is wrong. And that is an indicator of where we are. Well, so I started to think about this a little differently a couple of years ago. And I had this idea that I would go out and find healthcare companies that get wildly better results at much, much lower cost than conventional approaches. And this has become a thing. And I want to show this to you. And I want to show you why I now have clients like Michelin and Whole Foods Market, which is Amazon now, and Boeing and people like that, because they all see the logic of it. And they're going down this path, and it will change healthcare. I firmly believe there's a shot that it will change healthcare. But I want to show you what it means. Oh, by the way, I can't see the numbers from here, and I wish I could, but what this shows is the rate of stock price growth of the health plans in the country. It's important to know that health plans want healthcare to cost as much as possible because they make a percentage of the total. So they're not the least bit interested in general. If you think that Blue Cross or Anthem or United or Cigna or Humana is interested in a better way to do musculoskeletal care, you're mistaken, because it does, if they were, it would do two things. One is they would make less money. If the total spend is less, net earnings are lower, which means their stock price goes down, which means their market capitalization goes down. That's number one. And number two is they're simply going to piss off the providers in their network who don't perform at the level that they could be performing at. So we're stuck in a system that's holding us all hostage for lousier care. And that's the bottom line. But when you look at the math on stock price growth of the health plans, the major health plans, they've grown as much as 775% over the last 8 years. They've grown 2 to 3 times as fast as the Dow, and 1.5 to 2 times as fast as the S&P. It's absolutely spectacular market growth. And so you really need to think, if they're growing so rapidly, why are our costs so high? Well, we're fueling that. And they're just one part of the system. Of course, pharma has similar numbers. The hospital systems have similar numbers. And we're at the behest of all these organizations. So let's talk about modular solutions. Again, I can't see this very well because I'm old. But I have found what I will call high-performance healthcare organizations in lots and lots of areas. And I'm not interested, let me be clear, I am not interested in wellness or patient engagement. Those are like kissing your sister. We're looking where the money is. Okay? We want to know what's the stuff that actually works that will change the way that healthcare works. So what's the biggest area? Really, the biggest area is drugs by far. And by the way, drugs is not aspiring to be 25% of total spend, as was said earlier. By 2020, it's expected to be 50%. And I'll come back to the thing on drugs. It's the single biggest area of healthcare spend, and they have us bamboozled hook, line, and sinker. That's probably a mixed metaphor. Secondly, next is musculoskeletal. Musculoskeletal is 25% of group health costs, and it's 60% of occupational health costs. So hold that thought. Then there's cardiometabolic, and I say cardiometabolic as opposed to cardiology because we now know that it's not heart, it's respiratory, it's a whole array of physiologic systems that are interconnected and that consume hypertension and diabetes and metabolic disease and so on and so forth. And the fact is that almost all of the cardiology care that's delivered in this country today is wrong because we're still following a plumbing model. We know, for example, that stents in stable patients don't work. They don't provide any better result than patients on drugs. We're still doing stents like crazy because they're very lucrative, and so on and so forth. You get the idea. But after that, there's oncology. Oncology is 12.5% of total spend, and it is, for the most part, atrocious, just absolutely atrocious. 1 in 4 hospitals in America today is building a cancer center because it's so lucrative. 96% of the patients with advanced cancer in this country are going to die. We don't tell patients what the truth is about what their odds are with drugs. We don't tell them the truth about what they're actually going to face with adverse effects. And we push them through a tube and let them suffer because that's become the norm. And believe me, I speak with authority. I lost my wife 3 years ago, almost today. And I know what this is about. Oncology, dialysis, and it's not just clinical care. It's administrative and financial risk management as well. So let me give you an example of what I'm talking about. Like, let's dispense with the presentation because I can't see it anyway. But doesn't matter. There is a company in Tallahassee, Florida, that is run by 2 very senior physical therapists who are devotees of a subdiscipline of physical therapy called the McKenzie method. Comes out of New Zealand, extremely credible, been around for a while, but it didn't have a quality framework associated with it. So these guys built one. Now, what I mean by a quality framework is doing a thing to a patient and having a number of quality metrics that you're watching all the time. So maybe there are 6 or 12 quality metrics, and you're watching those anytime you do anything to a patient. And that's what they did. And every time they did an intervention that didn't get a positive result that they thought they were looking for, they stepped back, they rethought their clinical model, and they course corrected. And over a period of about 7 or 8 years, their model changed so dramatically and organically because this was a daily process. They did this with every single patient that they saw. It changed so dramatically that it became no longer physical therapy, it wasn't orthopedics, it's its own fully fleshed out musculoskeletal management paradigm. They now have clients like Michelin, General Dynamics, they just got the Army, they just got Dean Foods out of Texas and Oklahoma. And the data show after 100,000 patient encounters that they get not just better results than conventional orthopedic care, they get wildly better results. Range of motion, pain reduction, activities of daily living improve dramatically over conventional care. Recovery time drops in half. Cost drops in half. Now let's go back to the 25% and 60% number. This means that if you are a Michelin and you have 42,000 employees, and this was a quarter of all of your spend on the group health side, this means that by making one shift, by changing one vendor, they're going to drop their total spend somewhere on the order of 12, 13%. An absolutely spectacular number. We're talking tens or 20s of millions of dollars in this one company. And the data are there. I mean, it's very clear. And not only that, but it comes with some costs to the rest of the system. Surgeries in orthopedics drop by 2/3. Images drop by half. Injections drop by 1/3. So you can imagine how freaked out the local hospital and the local orthopedic practices have been where they are. But the point is, patients get better health outcomes and purchasers pay dramatically less for a better result. Now, is anybody flocking to it? Not in the public side, because lobbyists have influence over the public side. But are they flocking to it in business? Absolutely. Absolutely. The same thing is doable in cardiometabolic care. There are a number of groups around the country. One is in Greenville, South Carolina. There's another one in Spokane that have developed a better approach to managing cardiometabolic care that follows the evidence. In oncology, there are a number of cancer care management organizations that are led by nurses, by experienced cancer nurses. And a company that has, let's say, 10 or 20 cancer patients in a market will go to these companies and they'll say, we want you to do care management on our cancer patients. So these nurses get the sign off, and they go to visit the doctors who have the charts on these patients, and they review the charts, and they'll go to the doctor and they'll say, doctor, this treatment pathway that you have the patient on does not adhere to any evidence-based guideline that we're aware of. How are you justifying the treatment pathway that you've got your patient on? So what they're essentially doing is they're shaming the doctor to do the right thing. And what happens as a result? Emergency visits go down. Hospitalizations go down. Overall cost drops by 35%. Conversion to hospice increases 8-fold. Dramatic and common. And this is like the lie. There is a company in Virginia that is led by an ERISA attorney. Everybody know ERISA? It's the law that self-funded health plans are written under. And this attorney has inventoried all the laws and rules that define whether a claim is legal or illegal, which is different than if it's appropriate or inappropriate. An inappropriate surgery might be the spinal surgery that I talked about, but that's not illegal. An inappropriate claim might be a claim for a surgery where the doctor went back in to retrieve a sponge that got left in last time. Turns out that's illegal to bill for that. Another illegal claim might be to bill for a service that was already covered under another bundle, and so on. This group only looks at hospital-based claims, facility-based claims, and they only look at the claims that are 6 months old or less, because once they identify them, they're easier to recover from the hospital that got the money in the first place. They're recovering, on average, 17 to 25% of all facility-based claims that they review, which works out to between 5 and 10% of total healthcare spend. These are immense numbers, just immense. The other day, let's talk about drugs for a minute. Drugs are going to be half of total spend. They're about 40% of total spend now. You've got to understand that part of it is in the pharmacy benefit, part of it's in the medical benefit. Drugs are as complicated as the industry can possibly make them be because they're trying to obfuscate. And I found the effort on the agency here to get control of that, charming, but probably it's doomed to failure. I mean, the people who I know who are working in this industry and working on that problem, one of them built one of the 3 companies that now has 80% of the market share. He knows where all the bodies are buried. And unless you've got that kind of depth, there's no way to untangle this Gordian knot. But let's talk about that for a minute. So I work with 2 PBM consultants, pharmacy benefit management consultants. And one of the consultants is in Georgia, and he has developed a questionnaire that's really a list of demands that he hands out to all the PBMs in the country on behalf of his clients. And it says, if you want access to my clients, you have to agree to the following things that are on this sheet of paper. Are you willing to be transparent in the following ways? Are you willing to have an audit trail for us in the following ways? Are you willing to pass through the money in the following ways? And check you either are or you're not, one or the other. It went out to 73 PBMs. There was one PBM that agreed to all the terms, which means that they're busy hiding money. One PBM. So I go and I visit them. They live not too far from me. So I go and visit them, and I walk in. The guy who's the owner of the PBM he's got 13 million lives under contract. All but 3 million of them he's working as the back office for other PBMs. And he says, so I hear you have a boat. What kind of boat do you have? So I tell him about the dinky boat that I have. He says, I've got a boat. I said, what kind of boat do you have? He says, 130-foot sport fisherman. I said, really? I said, how much does that drink an hour? He says, 600 gallons. I says, your boat costs $2,500 an hour to run. He goes, yeah, but it's not nearly as bad as my 737. And he says, PBMs have been very good to me. He says, we are in the most lucrative industry in America. And he says, let's blow it up. So of course, I don't believe him. So I said, so how do the numbers work? And he says, well, when it all comes down to it, he goes, well, if you can bring me 250,000 lives or more, then we can have a net fee of $1. And I turn to my 2 consultants and I say, with all due respect, that can't be right, because the 3 biggest PBMs, CVS, Express Scripts, and Optum, they're charging $8 to $12 per script for the fee. And the consultants look at me and they go, no, he's right. That's what it's going to cost. And I look at him and I say, how much could we save the average employer just on the drug spend? And they look at each other and they go, 30, 35%. Think about that number for a minute. And then, then I say, how much can we financially guarantee that we'll save them? And they go, 20 to 25%. This is on half of the money. One thing, just the drugs. The money, the excess, the waste is so extreme that what it has made me understand is that if we put all of these structures under a single health plan umbrella, we can go to employers and we can essentially say, we can deliver better health outcomes, financially guaranteed better health outcomes for 30 or 40% of what you're currently paying. Which means that at a business level, you could go in and say, I'll financially guarantee that your costs will go down 25%. But you have to be willing to stand up and say, I'm not going to work with the local hospital and the local orthopedist anymore. I'm going to put together enough lives in my market. I'm going to work with these guys and do it that way. That's what it takes. Because we are so taken to the cleaners. We are so taken to the cleaners. And there's not going to be anything that we can do about it based on the discussion I heard today. I mean, I don't want to wear out my welcome, but honestly, you're in severe budget crisis because of this problem. And the level of understanding of what you're up against in terms of the problem that was expressed on this stage today was not very strong. I mean, people who spend their lives working in HealthCare, they know that it just wasn't very strong. So my recommendation to you is there's a way out. One of the things has to do with getting people in who don't profess to do it better, who have the data to do it better. There's something I left out, which I shouldn't have because I just forgot. So I developed questions. I get about 5 to 10 calls a week from companies who tell me, I've got the best thing since sliced bread. And I go, yeah, that's fine. Answer these questions first. And there are 6 questions. Believe it or not, you're going to think I'm a moron. These questions took me 2 years to figure out correctly. But they're really simple. And the first one is, so explain what you do in a paragraph or less that shows that you have a better value proposition. And it turns out, believe it or not, most people can't answer that question. They don't really know clearly what they do that's great. But if they do, we go to the second question. Show me longitudinal data that demonstrates that you consistently can deliver better health outcomes and or lower costs. And I'd like to see the arithmetic, please. 3, show me client testimonials that will attest to the accuracy of the data that you just gave me. You can have the slides, you don't need to take notes. The accuracy of the data that you just gave me, as well as the fact that you can execute without pissing people off. 4, can you scale? It's really great that you can do this in Tallahassee, Florida, but I need this done in Cheyenne. I need this done in Providence, Rhode Island. Can you do it there? 5, is it durable or sticky? It's really great that you're getting a result after three months. Are you still getting a result after 3 years? And can you show me that? And then 6 is the coup de grace. 6 is, are you confident enough in your ability to perform that you will put your fees at financial risk against the performance targets you claim you can achieve? And if they're not willing to do that, that says that they want you to go at financial risk for the performance targets they claim they can achieve. And that's something that everybody in healthcare assumes is the right way. Assumes that if you take a drug, the drug doesn't have to work. 2/3 of the cancer drugs that have been approved by the FDA in the last decade, there's no evidence that they work. They've been approved on the basis of progression-free survival, surrogate metrics. Might as well be kerosene. Honestly, this is the state that we've descended to. So it turns out that people answer these questions, and about 1 in 40 can answer all the questions correctly, and I get real interested in those. And that's how I sort of figure them out. And people call me and they say, check out this organization. And they're all over the place. You never see them in Chicago or Dallas. You see them in Lake Oswego. You see them in some suburb somewhere. And that gets us to the sociology of this, which is really great. It turns out that these companies are founded by people who are special. They're founded by people who are passionate and mission-driven about what they do. They are evidence and data-driven, and they have really high subject matter expertise in some niche that they're used to operating in. I mean, if it's an ambulance guy, he understands ambulances. He understands everything that there is to know about ambulances, and he worries about it. And they have deconstructed some problem in healthcare and come up with an entirely different solution than everybody else has. And then they tinkered with it to make it better, and sometimes it got worse, but they got it better again. But they tinkered with it, and finally they're so confident that they're willing to go at financial risk against the performance. And those are the guys that you want. They have one flaw, and that is no matter what area of healthcare they're working in, if you pull them all into a room and say, so what do you think the most important area of healthcare is? They all go, oh, it's the thing I'm working on. It's the ambulances are the thing, that's the big problem. And that's just the way it is. That's the human condition. The truth is that these organizations are out there and they're real. And I'm now getting organizations calling me and saying, okay, come in for the day. We're going to talk through each one, and we're going to talk about what order we use them in. And that, as it turns out, matters, because there are 2 vectors that should matter to a purchaser, meaning an employer or a union. The first is, what kind of resources are going to be required of me to use this service? And let me give you a couple of different examples. I used to own an on-site primary care clinic company, and it turns out that if you deploy a clinic company, you've got startup costs, you've got monthly costs that are going to be between 8 and 15% of total premium, and then you've got usually your facility costs, and the data say that you're not going to get an ROI. If you get an ROI at all, only a minority of organizations do get an ROI because most clinic companies, frankly, are rotten. But if you do get an ROI, you're not going to get one for 18 to 24 months. So if you're looking to save money, it might be better if you're not confident that the vendors you're looking at can actually deliver, and you're not going to get a guarantee from them. It might be better to go do something that's a little less ambitious but more reliable, like the musculoskeletal, like the cardiometabolic, like the drug management. So that's the first vector. What is it going to cost you? What's going to be involved in terms of your commitment to do this? The second one is how disruptive is it? Let me give you an example here using the drug management problem. So I've run across 3 major approaches to managing drug spend. The first one is a guy who's an analyst and gets your PBM claims data and rolls through them and looks at every single drug that's on your formulary and what you've spent, and circles the ones that are egregiously priced, because the PBM is monkeying with the pricing on a day-to-day basis so that you can't keep up. And this guy is going in and spot checking it, and he calls up the PBM and he goes, okay, this one and this one and this one and this one and this one, you need to change the prices on them to the following. And if you don't do it, we're going to shop the business and you're not going to be on the list. And so that one act reduces total non-specialty drug spend by 15%, which works out to 2.4% of total spend. It's a big number. The next approach has to do with the formulary. And it turns out that, I don't know how many people in here are aware of this, but the way that a PBM defines which drugs are going to be on its formulary within each drug class is that they go out and they ask for bribes. And it's that shameless. So if X PBM wants to work on a given class of drug, they call Merck and say, well, how much are you willing to give us to put your drug on the formulary? And whoever has the highest bid, their drug gets put on the formulary and they get used, and then they make it up because they have exorbitant pricing on the drug itself. So this has been a real problem for a long time in healthcare. So there are groups that have come together, particularly this guy who was the guy that built Optum, and he went home to where he was from, which was Little Rock, and he started working with the University of Arkansas Med School Pharmacy Department on building a true evidence-based formulary. And rule 1 is that we don't look at any studies that were funded by the drug companies. So we look at studies that come from Europe and Asia and South America, but not the US. And they define the drug in terms of its efficacy, its clinical efficacy, and then they take its pricing into account to come up with a value score. And that one act produces another 15% drop in non-specialty drug spend, or another 2.4%. Then there's the problem of specialty drugs, which is the overarching problem that we have in drugs, because now you're getting drugs that are $400,000 and $500,000 and $600,000 because, well, they can. I saw a statistic last week that last year, globally, we spent $1.3 trillion on cancer drugs, and 47% of it was spent in the US. Okay, so we're the suckers. So the way that what you can do there is first of all, you can change where prior authorization happens. Prior auth currently occurs at the PBM, which is selling the drug. So guess what? They always approve the drug. So big surprise. But what you can do is move prior authorization to an outside agent, an independent agent. When you do that, you move from a 99% approval rate to about an 88% approval rate. and saves immense amounts of money. Then you can work on the site of care, the facility, and the dosage, and those two activities save a lot of money as well. What I'm saying is that there are people within each of these areas. There's not a silver bullet in healthcare. There are 70 silver bullets in healthcare. And you have to understand what the problems are in detail so that you can understand what the solutions are in detail. And that is way beyond what any business person is likely to do. So there is a place in the world for people who examine each problem and figure out what each problem is, and then figure out why the solution is actually a really good solution. I have been more optimistic about the prospects for American healthcare since a group of us have figured all this out than I've been in the last 25 years. And it turns out this has now become a thing. So I work very closely with a conference that takes place in DC every year at the end of April, beginning of May, and I would urge you all to pay attention to this conference in the employer track, which is called the World HealthCare Congress. And we have put together a conference that is focused on innovative employers, innovative benefits consultants all over the country, and innovative vendors. And we put the innovative vendors through paces. We're also creating a new credential for consultants that say, are you willing to disclose all the sources of your revenue associated with any client? And if somebody's not willing to do that, they can't have the credential. Are you willing to show us that the advice that you deliver to your clients produces better results than the average results of cost per employee in your market? Because if you can't do that, we're not going to be interested in you either. We've got to do the same thing with employers to get the employers to buy into the process and say, we're not going to use a benefits consultant who hasn't been through this process, because everybody's got to be equally committed to a better path. Because the brokers have been all but criminals in this enterprise for a long time. These are the things that it'll take. This is institutionalized corruption at the level of American commerce. And it's not like I'm making wild accusations. There's no surprise about this. Everybody knows this is the way it all works. So there's a way out, but we have to think outside the box. And I would encourage you strongly to think about it. And those of you who are either, there could be two kinds of people in this room, those who are interested in buying services, and you should just focus on the high value services. I'm not interested in the low dollar spending. We're interested in the real high dollar spending. And they extend into places that I didn't talk about, but that are very powerful. There are companies that specialize in resolving very high cost claims. You got $1.5 million claim, they'll get it down to $700,000. That's what they do. There are just all kinds of nooks and crannies. I got a call 3 months ago out of the blue from a company in La Crosse, Wisconsin, that does a better job managing allergy patients than conventional care. And now I've looked at the math, and they get way better results at 40% of the cost. And when I asked them their most important statistic that they had to tell me, they thought a while, and then they said, we have 15,000 regional patients in and around Wisconsin, and the average patient drives 250 miles one way to see us. And I thought, provider of last resort. So there are cultural memes that are erupting around these groups. The people who use them are sold. We have to find a way to get them into the marketplace, and if they do, it will be a bottom-up change in healthcare, and it will have dramatic impact, and it will force every other component of the health system, the doctors, the hospitals, the health plans, to change the way that they behave because otherwise they can't compete in the market anymore. That's everything I know. Thanks. I want to say I made that up, but I actually didn't make that up. Any questions? No? What a shy and retiring group. No. Yes, ma'am?
So, this might be for a private conversation about kind of what do you do besides give these kind of talks and the different companies that you consult with. So I'm curious if you've ever helped a delivery system, look at how to be much more cost effective in how they do that.
You mean a health system?
Yeah.
Yes, I have, except most health systems at the end of the day aren't the least bit interested because they worry that at the end of the day, if they do these things that'll make them better, they'll have lower per patient revenues. And that's the dilemma. I just spent time with the Providence Health System and specifically
Seattle.
Yeah.
Got it.
Yeah, but that's the problem. Health systems are not likely to be for it, even though strategically it makes sense. If you can go out into the market and first work on your own employees and show that you drove down the cost and improved the health outcomes of your own employees and their families, you can sweep the market of employers in the community who you promise you'll do the same thing for them. But nobody wants to put in that effort and make the changes because the changes are ultimately about making less.
You've not had one system say they wanted to do that?
It's like saying.
Your income's going to go down.
Well,
you make it go down.
it's the human condition. People respond to the same incentives. Anybody else? Yes, sir.
So a lot of the points you make are made by supporters of a single payer system.
My view is, let me just state it outright. I'm a lefty, and I would normally really, really support a single payer system. But the problem is that Congress is owned by the industry, and they currently control half of the healthcare system outright. And if we had a single payer system, they would control all of the system outright. And it turns out that Congress is for sale pretty cheap. So if we had any other design in our governance, that might be a good idea, and I'd buy into it. But I just think that we've got a long history of creating policy by special interests that is absolutely not in any of our interests except for the companies, and I think it's a real problem. It's a real problem. Well, that was a downer, wasn't it? Anybody else? Thank you. Oh, yes, ma'am.
I would just comment that the American Nurses Association last year did come out with the fact that it's a patient's right to have palliative care. And your stats with hospice care going up as they get, with cancer treatment, as they get the truth to them. And that I've seen that, and we are not utilizing our palliative care and our hospice care like we should. And the FDA is approving these cancer drugs that literally give these patients 3 months of living. And it's not quality.
First of all, nurses rock. That's number one. Number two is that my wife went into palliative care 5.5 months early. Yeah, it was very positive. The third thing that I would tell you is that there's a really important study that appeared in, I think it was JAMA, this is about 3 years ago, on small cell lung cancer, and I think it was at Mayo. And what they did was they took a cohort, the entire group of patients with this kind of cancer, and everybody went through first-line chemotherapy, and everybody failed at first-line chemotherapy, as everybody does. And then at that point, they bifurcated the group, and half of the group went into palliative care, and the other half of the group went into aggressive chemotherapy. And the findings were that the people who were in palliative care lived 60 to 90 days longer than the patients who went on chemotherapy, and they reported a better patient experience because they didn't have all those goddamned adverse effects.
Amen.
And the adverse effects, it's not losing your hair. For those of you who have never been through it, it's death by 1,000 cuts. You know, it's bleeding from all of your orifices. It's tremendous headache spikes. It's neuropathies. It's your intestines going from diarrhea to concrete and back, and on and on and on. The way we are managing cancer care in this country is an abortion. Absolutely. Yes, sir.
Let me just make sure I understand.
I wasn't clear enough?
Hold on, so it's not Congress, that's not the answer. The health systems aren't going to make the change. The change will have to be triggered by the big groups that purchase healthcare, like
The change is going to have to happen. There's only one place that we have leverage, and that's the market. And purchasers of all types in healthcare still make purchasing decisions. And so, like, if you've got 1,500, 2,500 employees, and you go to United and you say, I want to use this musculoskeletal management company, they're going to say, absolutely not, no way, hit the trail, because you're too small. But you can always go to a third-party administrator to do it for you. There are alternatives. So what I see happening is, the level of frustration, this is another thing, I don't know how tied in you are to it, but the people that I talk to purchasers, I talk to employers and unions, and they are absolutely freaked out, frustrated, because the costs are so immense. And the idea that has been perpetrated is, well, this is just what healthcare costs. I heard a statement earlier that the health plans don't influence costs, they just tally up the total. That's complete and utter tomfoolery. That's utter nonsense. Health plans make dozens and dozens and dozens of decisions about who's going to deliver what kind of care and what's going to be approved and what's not, and how much everything is going to get paid. They're making, and what programs are used, who the vendors are. They're making all kinds of decisions to promote more expensive, poorer quality care. And that's documentable. So, yes, the one place that we have leverage in the system is in the market. We don't have leverage, and it's a waste of time to worry about trying to get policy change because they own it. They have unlimited money. There's no way you can fight against them. Does that make sense?
Okay, yeah.
Well, that got everybody's riled up now, boy. Okay, thank you so much.